based on a huge database of patients who didn't do well, and that's why he came up with a score called as the ICH score. Okay, the ICH score 2001, when he actually did this scoring and showed it to us, it was actually a very well validated score for risk stratification of patients. Okay, it was actually done for outcome risk stratification. When you say outcome means जैसे आपने बोले कि GCS less than 8 रहेगा तो the outcome is not good. That is the reason that they made a score, because what is happening with IC average, though the incidence of IC average is only 10 to 15% among the total amount of problems that are occurring, but the prognosis is very poor of these patients. IC average, it's not this way that you operate a patient, the patient gets better. IC average has proven again and again that all your interventions don't seem to work. In ICH, unfortunate, it is very unfortunate that in spite of so many years of work in intensive care and in neurosurgery, we have not been able to change the mortality of patients with IC average. Right? So we always thought that IC average would change if the treatment effects would work if the IC average was different. For example, if the score, so that's why they put in a score in place to actually do research. To research to understand which IC average will respond to a surgery. Which IC average will respond to a surgery, to know that they actually put this score in place. Now what we did, they did a huge database and they found out mortality benefits and mortality, which patients are dying. So this age was very, very important there. The age was very important. That's why once you have an age more than 18, you start thinking 100 times before you do anything for this particular patient. More than 80, you start thinking 100 times. Okay. Now this volume, another very important part. GCS we know, but GCS is used as a part of this particular scoring. It's part of the IC average scoring. Okay. Now the volume is very important here. Now when you say IC average, maybe you call it small, medium, and large. Say today you want to communicate to me. I'm in the hospital. I'm in that home, or Dr. Mahesh Chaudhary is at home, and you want to communicate to him. You want to tell him about the IC bleed. Now it becomes very simple. You WhatsApp the entire thing to him, and he has a look at it. It becomes simple that way. But otherwise, say you want to communicate to him, how do you want to think whether it's a mild bleed, or a small bleed, moderate bleed, or a large bleed? How do you differentiate? By the volume, isn't it? By the volume, you will determine by the volume. When you say you want to say that it's a small volume or moderate or large bleed, you will look at volume. So in that, what we know is that if it is less than 30, it is small volume. If it is less than 30, it is small volume. If it is more than 60, it is large volume. If it is less than 30, it is small volume. More than 60, it is large volume. So when you actually showed us volume, the formula is very important. The formula for volume calculation is very, very important. The formula for volume calculation. This is the formula for volume calculation. So you can actually calculate the volume, yourself. How do you calculate that? So you calculate that by looking at the film where the hematoma is maximum and find the maximum diameter of that. Find the film where the hematoma is maximum. So you have series of films, right? You have different cuts. So in that cut where the hematoma volume is maximally seen, look at the maximum diameter there. Look at the maximum diameter. Note it down in millimeters. Okay, note it down in millimeters. Now once you note that diameter in millimeters, drop a perpendicular in that, on that same line. Drop a perpendicular on the same line. So if he has found out this as the maximum diameter, 5.17 in the film, he has dropped a perpendicular on that. So that is B point. This is point A. This is point B. This is the length B. Okay, you do that. After doing that, then you find out the number of films in which you can see the hematoma more than 75%. Good morning, sir. Yes, good morning. Then you put a drop of perpendicular, and then you see the number of slices where the hematoma volume is more than, where the hematoma size is more than 75%. You don't see these small, you don't take all the slices. So you take only those slices where the hematoma seems to be at least 75%. समझ में आ रहा है? अभी इतना बड़ा है, फिर इतना हो गया, फिर तो इधर चेक कर लिया आप लोगों ने. उसके बाद जो छोटा हो रहा है ना, उसको हम लोग काउंट नहीं करते उसमें. समझ में आ रहा है? And then you multiply it by the thickness of each line. एक ही स्लाइस का थिकनेस क्या है मिलीमीटर्स में. So then you multiply all of these together, and then you get the volume. Clear on this? Volume estimation. So you look your film will have multiple areas where you will see one एक में दिखेगा हेमेटोमा, दूसरे में दिखेगा हेमेटोमा, तीसरे में दिखेगा हेमेटोमा, ऐसे बहुत सारे फिल्म्स रहेंगे हमारे पास. So you see that film where the hematoma volume is maximum, where you get the maximum diameter. Like for example, they have seen maybe 10 films and they found this particular film to have maximum diameter. And what they have done is they have drawn the line for the maximum diameter film. So they've got the maximum diameter. This is point A. This is number A. Okay. So for example, 5.17 is A. Okay. Now that same film, you drop a perpendicular on that particular line. So whichever line or perpendicular you get the maximum diameter, that is B. Like for example, you could drop it here, you could drop it here, you could drop it here, you could drop it here. But on this same film, the maximum you're getting is this one. So that is point B, that is number B. So A into B. Okay. Now you look at how many of these films are there, similar films in that CT scan. In that CT scan, कितना films है, कितने cuts है, कितने cut sections है. You see how many cut sections are there, and count the number of cut sections where the volume is more than 75%. Where the volume of this hematoma is more than 75%. तो इतना रहेगा, इतना रहेगा, इतना रहेगा. एक बार इतना छोटा हो गया, then you don't count that section. Okay, so you count those sections and multiply it by the thickness of each cutter. Multiply it by the thickness of each slice. बोली या तो फिर सीधा CT scan से पता चलता है, नहीं तो CT scan पे लिखा हुआ रहता है the scout film. There's something called scout film in the start where you have these lines. So उसमें से नहीं तो you find it from the CT scan what is the thickness of each slice. Multiply it, divide it by 2. Multiply it and divide it by 2 and you will get a volume. That is your volume of that particular. So it's very important to understand that this volume becomes very, very important. So if you want to tomorrow communicate to me as to IC bead kaisa hai, so you say massive IC bead once the volume is more than 60 ml. Okay, very severe IC bead, very severe massive IC bead if it's more than 60. 30 to 60 is moderate and less than 30 is small intracerebral hemorrhage. So what is known is if it is small, then you see the points become 0. Clearly indicating that the prognosis kind of may change. Okay. Now another very important part of the story is intraventricular hemorrhage. What is clear is if there is IV hemorrhage, intraventricular hemorrhage, irrespective of what is the size of the hematoma, you know the prognosis is poor. Intraventricular hemorrhage. That's why it's very essential for you to look at intraventricular hemorrhage. And infratentorial origin. So this is another very difficult problem because here what happens over here is different from what happens in the cerebrum. So cerebrum there is space. Whereas infratentorial there is less space. So the volume though may be small, volume may be 10 ml, but for that infratentorial hemorrhage it is too much. That's why the infratentorial, you understanding? So you have supratentorial and infratentorial. In the supratentorial area there is a lot of space, whereas in the infratentorial area there is very less space, where the pons is lying, where the brainstem is lying, very less space is there. So in that, even if a small hemorrhage goes to the pons, say it's less than even 10 ml. We just not talked about 30 ml being more small, but in the pons, if it is even 10 ml, okay, or in the brainstem it is 7 ml, you know, it is actually very dangerous. It's actually very, very dangerous. Okay, that's why infratentorial origin of the hematoma becomes 1 point, becomes 1 full point. You are understanding? So irrespective whether 5 ml भी रहेगा, 5 ml ये तो 0 हो जाएगा. लेकिन ये अगर infratentorial अगर हो गया 5 ml भी अगर हो गया तो 1 point आ गया होगा. You understand? So when you are communicating and you find the hematoma to be small, your communication should be, sir, we have got a hematoma, now it is around 10 ml, but unfortunately it is infratentorial. Hello? Yatin, it's interesting in your case that Rohini Amre. A little bit better. What were we talking about? So now let me put you to another part of the story. What you must understand clinically. See now we say the ICS is very interesting. You know that ICS score हम लोग के पास आ गया, powerful tool आ गया. Now it's unlike GCS, it's giving you prognosis, and look at the prognosis what it's giving you. If you have a patient who has a volume of 5 ml. Let us put a 5 ml volume infratentorial at an age of 82. Let us put that. So age is 82. His GCS is 4/15. Okay, let's put it as GCS is 4/15. Infratentorial person, infratentorial 5 ml hemorrhage, 82 years. Okay, and patient has since what happens in an infratentorial hemorrhage? What happens usually is, you know, you have infratentorial hemorrhage, there will be obstructive hydrocephalus, and because of that patient GCS will become very low. Infratentorial means, you know, it is lateral horn draining into the ciliates, you know, all those things, systems and all. And then you have infratentorial to नीचे ऐसा hemorrhage हो गया तो obstruction हो गया वहाँ पर. You know, in hydrocephalus there are two types of hydrocephalus: obstructive hydrocephalus and non-obstructive hydrocephalus. What is obstructive hydrocephalus? Or what is non-obstructive? How much CSF is produced per day?
180.
Per hour? Per hour? I was about to get to that also. Possible. What are we talking about? CSF. So how much per hour is produced? As doctor sitting here, you should know that, because say tomorrow you have a patient on an external ventricular drain or a lumbar drain, which CSF people put, you know, when you have a brain injury, people put lumbar drains, isn't it? Lumbar drains. So how much should it be per hour? It's 20 ml per hour. You must remember all these things. It's not something you should forget. 20 ml per hour is something you should never forget. You should never forget this, that approximately 20 ml. Because tomorrow if you have a lumbar drain which has come from operation theatre, as doctor sitting over there, if the drain is more than 30 ml, what you should start thinking, boss ये ज़्यादा बैठ जाएगा brain इसका. अगर वो 30 ml मैंने drain कर दिया तो brain बैठ जाएगा. I have to stop this so much of drain. Are you understanding? 20 ml per hour is an approximate drain that approximates CSF production. So you can imagine how superb production is happening in your each brains. Such a small place, and 20 ml getting produced and there is hardly any space. If you look at it, there is hardly any space. Where is the space? There is hardly any space. It's unlike your abdomen where you have massive space, you can accommodate liters and liters of fluid. Here, there is hardly any space, and it is creating 20 ml an hour, which is a big amount, which is a very big amount, isn't it, for this space? You understand? This space is so small. The space is so small, tiny space. Put that tiny space 20 ml per hour. Are you understanding? 20 ml per hour is coming in that. So you must remember this, okay? So in that, if I would put a lumbar drain on the back and I drain out 30 ml, your brain will shrink and will collapse, isn't it? So as a doctor in the ICU, you should know this, because if you have a lumbar drain in place and too much of drain happens, patient will not do well. You understand? So what happens in a non-obstructive hydrocephalus? Anybody?
More production, sir. More CSF production is there.
Okay. What will happen? So what will happen? What is normally happening? What is normally happening? If this 20 ml is happening.
Absorption of CSF is not a problem.
So what is normally happening? So this 20 ml is going where? अगर 20 ml बनता गया हर एक घंटे में, so by the end of the day you will have 500 ml, isn't it? कहाँ जा रहा है ये? So by the arytenoids, you know, there are these choroid plexus and all is there. So the CSF is getting produced at 20 ml per hour and getting absorbed, and it gets out by the CSF from the lumbar spinal canal and all gets out. That's why it's in continuous circulation. So when you have non-obstructive hydrocephalus, it is in circulation. But unfortunately, either the choroid, they are not absorbing or they are producing more. Either they are producing more or they are not absorbing. That is non-obstructive hydrocephalus. Are you understanding? It is non-obstructive hydrocephalus. It will occur in different kind of diseases. It can occur de novo. It can occur anyway. That means that's why that responds what to what? Just removal of CSF. It will respond to just removal of CSF because CSF ज़्यादा है इसकी वजह से उसको प्रॉब्लम हो रहा है. CSF ज़्यादा है इसकी वजह से प्रॉब्लम हो रहा है. इसलिए तुम्हें lumbar puncture हो, patient will get better. समझ में आ रहा है? Patient will get better. Clear on this? Because you are just removing some amount of CSF, patient starts getting better. That's the principle behind doing normal pressure hydrocephalus, non-obstructive hydrocephalus. Okay. Whereas an obstructive hydrocephalus, so what will you see in non-obstructive hydrocephalus? Everything will be open veins. बड़े-बड़े horns रहेंगे, सब बड़े-बड़े रहेंगे. So everything will be symmetrically dilated. Like horns will be big, ventricles will be big. Everything will be big because CSF ज़्यादा है, pressure पे है. Now what about obstructive hydrocephalus? What is that? What does it logically mean?
So space occupying region causing compression. So
So in the system, that is from the ventricle, frontal horn, lateral horn से आ रहा है नीचे जा रहा है, किधर ना किधर block हो गया है. It might be third ventricle, it might be brainstem, it might be lateral horn, it might be anywhere. किधर ना किधर block हो गया है because of either tumor or infection or bleeding. or bleeding. Okay, so say for example, it's in the infratentorial region. Okay, the pons where the aqueductus sylvius is there, and pons is there, and brainstem is there. A small bleeding there will actually occlude the CSF. So when it's occlude the CSF, तब करके वो dilate होएगा. This is called obstructive hydrocephalus. What did we discuss? The reason for this problem was small bleeding. But what has happened because of that? The hydrocephalus has occurred, which has caused the patient's GCS to go down. It's not the bleed, it's the hydrocephalus. It's the hydrocephalus. So in short, if I put a drain there in the hydrocephalus, if I decompress and put a drain there, patient will become normal because bleeding तो actually छोटा है. Problem किसकी वजह से है? So now let's go back to our case. Our case was an 82-year-old gentleman who basically had a 5 ml bleed and he came with a GCS of 3/15. You have intubated. What is the ICH functional score? 4. Let's look at it. GCS 4 is how much? 2 points. Volume is less than 30, so 0. IV average not there. Infratentorial origin, yes. कितना हो गया? 3. And 4. Now at 4, what is the mortality?
97.
इसको ड्रेन डालेगा तो ये तो उड़ जाएगा ना. इसको ड्रेन डालेगा तो ये तो उड़ जाएगा. Are you understanding? So can the mortality be 97%? It's not possible, no. Are you understanding? So as a clinician you should think. हाँ, अगर उसको मैं 97 mortality बोलूँगा तो मैं बोलूँगा इसको कुछ मत करो, you will die. माफ करो, 97 mortality is too much. हम लोग 5% से ऊपर बोलते हैं high mortality, 3% से ऊपर भी call high mortality. 97% मतलब कुछ भी करने का कोई मतलब ही नहीं है, nihilistic हो जाएगा हम लोग सब लोग. If you look at the ICH functional score and now put this same patient into ICH functional score, you say 97% mortality. चलो कुछ मत करो. This will be your thinking. समझ में आ रहा है? समझ में आ रहा है? But that should not be the thinking because you know as a clinician that if I put a drain, this patient is going to turn around. Different casing. समझ में आ रहा है? That's why you must each score you cannot just take it as a score. You're not just thinking a 97% mortality. नहीं भाई. You look at the context and then you take a call what is to be done. That is why we say ICH functional score, though it is a fantastic score, validated, AHA, everyone has told do it, ESO has said do it, do it, but you still, it may develop a nihilistic attitude towards your cases. When I say nihilistic attitude means, ये तो वैसे भी जाने वाला है. वैसे भी जाने वाला attitude नहीं आना चाहिए with this score. Remember this. You understand? We know the mortality is high, we know that these patients functionally don't do well, but you cannot be 97%. You understand? You must understand this very important point that I'm telling you. Okay, so ICH functional score is a great score. I am not telling that it's a bad score or anything. But you must know how to interpret these scores. You must know just like a GCS how we interpret it. You should know how to interpret these scores. Okay, so how does the score help? Like for example, now I want to do some kind of therapy. For example, this patient is there with this hematoma. मेरे मन में आएगा, चलो यार, what will a normal person say? इसको निकाल दो. What will a normal person say? अगर तुम if you have IC average, this patient will do well if I just remove this out. बराबर? ऐसा normal logic है ना कि hematoma है निकाल दो hematoma. Logic, that is logic. You are understanding? That is logic. But now whether this patient will do well or not, I will have to see whether यही patient इसका hematoma इधर है. भले ही इसका hematoma अगर इधर होता तो क्या होता? इसका hematoma अगर इसके अंदर होता तो क्या होता? इसका यही hematoma इधर होता तो क्या होता? ये पता करने के लिए मुझे कुछ तो metric चाहिए ना. तो ये metric इधर आ जाए. So if the ICU functional score is ICH score is this, I will attempt doing this. हमको पता है कि अगर इधर का hematoma मैंने निकाला versus इधर का hematoma मैंने निकाला, this patient will do better than this patient. Why it will do better? Because if the hematoma is 1 centimeter closer to the calvaria, you are not causing any brain problem. You are immediately able to take off that hematoma. Are you understanding? So obviously this patient will do better than this patient. How will I know this patient versus this patient? Functional score. So now I put up a statement saying that whichever patient has got an ICH functional score of 1, I will do surgical intervention. समझ में आ रहा है? If those patients, I am able to direct therapy to these things to understand what's happening. समझ में आ रहा है? Direct my clinical research on this. Clear on the ICH functional score? This came from University of UCSF, University of Columbia, San Francisco. वहाँ से ना they came up with this particular entire database. They looked at that database and then they came out with this validated score in 2001. In 2001, that was my first conference abroad. So I had seen him showing the world, this is what we should be doing henceforth, and that became gospel. At the moment, you have to do, if you have a functional, so the JCI recommends that if you want to be called yourself a stroke center, you have to do the ICH functional score within 2 hours that the patient has arrived into the hospital. If you want to be called as a stroke center. Okay, so if you want to be called a stroke center, the JCI mandates that within 2 hours you calculate the ICH score. So all of us when we are actually looking at IC hemorrhage, we shouldn't talk off our heads. IC will okay. We should talk about functional scores. We should talk about ICH score. We should talk about GCS. We should just say ICP. It doesn't make sense. ICP is some nurse will tell you ICP. We should be telling the ICH score is so and so. So we have a reasonable estimate as to what is going on. Clear? Any doubts about how to calculate volume? What you have to look at? It's so simple actually if you look at it. It's very simple. So similarly, when you also know how to use it for your practice. For example, as I told you about that hydrocephalus patient. You can also use it for the practice. Thinking, okay, key score, I think I'll not use this score, though the ICS score is so and so. But I'll probably this patient may change depending on what it is. Clear? So next.